Ok, bienvenidos todos. Buenos días. Yo soy Benjamin Lee, presidente de Rayos Contra Cancer, y estoy aquí acompañado con unas personas muy conocidas. Tenemos a César de Aviancia, que ha sido nuestro educador hace muchas sesiones. Ustedes ya lo conocen, y él va a ser moderador hoy. Y tenemos a Dr. Robert Timmerman de University of Texas Southwestern de los Estados Unidos. Uh, Muchos dicen que él es el padre de SBRT y agradecemos mucho a Dr. Timmerman por todo su trabajo que ha contribuido al campo de radioterapia. Y es nuestro honor tener él hoy para compartir sus perlas y su conocimiento de SBRT de pulmón. Y queremos agradecer a la Asociación Colombiana de Radioterapia, ACRO, la doctora Lina Loíza y Active con Juan Camilo por su apoyo y por su sponsorship de esta sesión. Y es gracias a ellos que podemos tener la traducción a español hoy. Si ustedes quieren escuchar en español, ah, ah, hace clic abajo en la pantalla donde dice interpretación y selecciona el cuarto español. Pero si quieren escuchar en su voz nativo en inglés, ah, no hay que hacer nada. Entonces, y si tienen preguntas, ponerlo en el chat. Am, y ahora yo dejo el floor a Dr. Timmerman.
Oh,
So,
okay.
Dr. Timmerman, you're welcome to share the screen now. And
Okay.
we're very excited to have you today. Thank you so much for coming.
Oh, good. Thank you for inviting me. I think this is really a good program. And tell me if you're able to see my screen. Oops. Do you see my screen?
Mm-hmm. Yeah.
Yeah, perfect.
Okay. Well, welcome and thanks for the well wishes that have been coming across. I appreciate it very much. This is our center. On the left is the center we built in 2017, and that one houses some nice C-arm Linux, a gamma knife and a not a gamma knife, a gamma pod, which is a breast gamma knife sort of. And then it's got a CyberKnife M6 and so like a superficial radiator. And then on the right is the one that we just moved into a year ago, and that's got two MR Linux, two Ethos systems, two Halcyons, and then PET Linux called Reflection. And it's a busy center, and it includes these new machines that I just mentioned that do adaptive therapy. And that's all well and good, but I think that technology, it's still a good treatment is one where you just sort of start with the basics and have good conduct of treatment. It turns out for these, the workflows are really critical. Otherwise, you can really get bogged down or make a mistake. And I think that to avoid that, you again get back to the principles. So I hope this is okay, but I'm going to talk about some really basic things related to lung stereotactic radiation. And really important in that is immobilization and how you get the patient in the treatment position. And the goal has to be that patients are comfortable for these treatments, which tend to be longer than 2 gray perfraction treatments that I was trained to do. And the treatment sessions then can lead to people moving because they're uncomfortable. And we've seen this a lot now since we've gotten these cine MRI scans that show the patient in real time while you're treating them. They're squirming around, and so the key is comfort, and you have to really support them uniformly to get good comfort. Even though people think body frames are old-fashioned, we use them as a form of immobilization. And what they do is they facilitate a really comfortable setup. And we have these enormous vacuum bags, and they have different amounts of styrofoam fill in them. And so if what you're going to do is you're going to fill the body frame with either the patient, excuse me, or more fill from this vacuum bag. And when we treat in the chest, we pretty much always treat with the arms up. And that's one of the bigger problems, in that patients don't like to have their arms up. They get uncomfortable. We prop them up because they're really uncomfortable flat. So we put them on an incline, and then we put their knees up. You'll see this in a second. And then I used to give everybody dexamethasone, which is a steroid, before each treatment. But now with immunotherapy, we're not doing that as much anymore. But if they have regular pain medicines, or they could take Tylenol or ibuprofen as well. But kind of have it on board when you get there. Don't get them in pain and then try to fix it. Try to prevent them from getting into pain. So here's what I'm talking about. You're going to fill this body frame, and we've made them out of wood. Just have a cabinet maker make these frames. And this one is actually a commercial brand from Electa, but you could just make them out of like a plywood or something like that. You'll see them on the scans, so you'll be able to correct their attenuation, and it's very minimal. But the conduct is important. You just do not want the patient to hop on to these set. So you have this wedge under their shoulders, and you have a wedge under their knees, and the patient lays there. And then gravity is not such a problem, because if you don't put this here, for example, they'll slide toward their feet. And if you don't put this one here, opposite. And they're more comfortable with their head up like this, because people with lung cancer often have pretty bad emphysema, and that works better. So their arms have to be very well supported. And so this back bag can extend way up here if you need it to support the arms, because if they're not supported, then the patient will have to hold them up with their muscles, and they'll get quickly fatigued. And their head is up, and then their knees are out. So that's pretty straightforward, but if you don't do this, you just get an unstable setup. All right. And we avoid rotations, especially with our C-arm Linacs, because it can really dramatically the isocentric treatment helps you avoid the consequences of rotations, but you should try your hardest to let them go. And like, we have a CyberKnife, and rotations are just the killer of a CyberKnife. And if you do treat more than one tumor, my advice is to put an isocenter in each lesion, unless you have a way to, really correct the rotations and have the plan realigned correctly. Otherwise, it's just better to put an isocenter in each lesion. And then our strategy is, again, we support them on three sides. They're touching that bag on their back. They're touching the bag on both sides of their body. And then we use the body frame again to correct that. And then you can use your fancy couch if you have one. Most of our machines don't have those couches that can correct rotations, but a few of ours do. But for most of my experience, we did not have those couches. And so then next thing we do is we register the patient to the frame somehow. And in this case, again, it's a commercial product, but it doesn't have to be. This could be made out of plastic or wood. And you're just trying to bring a pointer down and then mark it. And if they were rotated, that pointer would hit at a different spot the next time. So this also corrects rotations. And then we always say, let the patient lie the most comfortable way they can, even though their arms are up. let them lie the way they can, and then move the beams. Don't try to insist that they lay in this position that's uncomfortable for them. Let them lay the way they want. And so we put them on this back bag again. Doesn't that even look comfortable when I showed you that pillow that they lay on? And then don't have preconceived beams. Just move the beams wherever they miss the organs that you're trying to avoid. Never treat people prone if you can help it. I haven't treated somebody prone in so long, I can't remember. Even craniospinal radiation, we don't treat them prone. Because it does a couple of things that's very uncomfortable. And second, it causes breathing motion to go to even structures like the spine. Whereas if you lay on your back, your spine hardly moves at all. So don't do prone if you can help it. And then we assess motion. And so what we're hoping is that if there are two patients and one person's tumor moves like this and the other patient's tumor moves like this, we would rather treat the one on the right. It's the same tumor, so you'd ideally not treat this huge expansion to cover the extent of the motion. And so the first thing we do is we do a motion assessment. Sorry? We do a motion assessment. And so what you're trying to do then is first just ascertain how much the tumor is moving. And we used for years fluoroscopy to do that. But it was only 2D. So doing a mini 4D CT on your scanner is a lot better because then you can see it in multiple directions. And so that's what we do now mostly. We do a mini 4D right around the target and see how much it's moving. And you could use the diaphragm, but that's a problem if the maximum motion in the chest is on the diaphragm. And so you may have a lesion that's in the chest and you're using the diaphragm as the surrogate and you're going to over predict its movement, and that's a shame because you'll treat it extra long that you don't need to. And you want to know if the motion is regular or irregular in terms of its period, its amplitude, and then the magnitude of the motion in terms of what directions it's going in, how much is it going in those directions. And it turns out that breathing motion is mostly craniocaudal, although the diaphragm is such a curvilinear structure that you end up getting motion in multiple directions, but it's still mostly craniocaudal. And then can you change that motion? What can you do to change that motion? And this is something that you got to watch out for because this is normal breathing. Normal breathing is incredibly irregular. And in all the journal articles, they always show motion as being perfectly sinusoid, but it's not. It's very irregular because people might be breathing regular, but then they'll think of something and take a big breath and then not breathe at all for a while and then start breathing again. And this kind of irregular motion really screws up any kind of like 4D CT or something because they're assuming the sinusoid again. And this is normal. Sinusoid is not normal. And it can, like I say, really confound the 4D CT. The 4D CT can construct interesting reconstructions like the maximum intensity projection or the minimum intensity projection, but they all assume in their reconstruction that the breathing is regular, both in terms of frequency and magnitude. And then that can goof up your motion envelope. We use this internal target volume definition, which is basically wherever the tumor moves, it will still be in this volume, this motion envelope, and it'll confound whatever motion control mechanism, which we'll talk about in a second, including gating and tracking. So in terms of the targets for lung cancer, let's say you have this tumor in the lung, and that would be called the GTV, right? The gross tumor volume. And then there might be some tentacles coming out of the tumor. So that's the clinical target volume. And then that thing can move around. So that becomes the ITV, the internal target volume, or motion envelope. And then you have slop in terms of your setup. And so you add even a little more, and that's called the planning treatment or target volume. And the point is here, we had this nice small tumor, and yet now we're treating this enormous area. And in this particular example, the volume of normal lung we're treating just to cover the target is considerably bigger than the gross tumor itself. And that's a shame. And so for lung cancer, what we always did in those trials that we did was that we assumed that, number one, let's not have any additional CTV margin. Let's just target the tumor. And the way we sort of justified this, we were at least consistent. You may not agree with what I'm about to say, but we were at least consistent. And so we would contour in the lung window, which made the target always a little bigger than if you contoured in the soft tissue window, and maybe we were getting most of those tentacles. I really urge you to use IV contrast, even for a lung nodule, because this case here shows it perfectly. So here's this tumor, and we drew a blue line around it. But what is this stuff here? This stuff out here is atelectasis caused by small airway obstruction by this tumor. And I know that that's atelectasis if I use contrast, because it will be duller, because atelectasis does not enhance, than the tumor. And so then I can differentiate atelectasis from tumor by using IV contrast. And then, like, there's a white dot here and a couple of white dots here, and those are blood vessels, of course. And sometimes it's hard to tell on the edge of the tumor. But again, IV contrast will differentiate that. And so we use IV contrast for all lung simulations, unless they just have horrible renal function. And I'm glad when I do that, because there's many times where somehow I got talked out of it. And then I wish I had it, because when you do a stereotactic treatment, you want to do anything you can to make the target smaller, because smaller targets just have way less toxicity. And that's different than when I was trained. When I was trained, and I was trained in the late 80s, early 90s, the lesson was, when in doubt, expand your field. If you don't know for sure where the tumor starts and stops, then just make it bigger so that you catch it. And that was, again, in the era of 2 gray perfraction. But when you're giving 15 or 20 gray perfraction, you cannot have that point of view. Your point of view has to always be, I want to do whatever I can to make this target as small as possible, and at least at the gross GTV stage. And so we fuse a lot of images as well to try to help with that, and that might be helpful. And then we also want the CTV. Now remember, GTV equals CTV. We want the CTV to be equal almost to ITV, but that's not possible sometimes because of the respiratory motion. And so, the tumors away from the influence of the diaphragm. For example, if you have a tumor in the apex of your lung, that doesn't move at all, because the apex of your lung doesn't move at all. And then many other structures are many other tumors can be tethered to a structure that doesn't move, like the mediastinum or something as much. And so you have to assess each tumor independently to say how much it moves, and they don't move the same as the diaphragm. And so if that's true, if you want the ITV to be as small as possible, what if one patient breathes like this and another patient breathes like this? So they've got a much bigger ITV. And so the toxicity difference between these 2 treatments could be quite significant. And if the free breathing is this big one, maybe there's something we can do to make it more like ITV1. And what we do then is something called motion control. All I've been describing to you so far is called motion assessment, but now we're going to do motion control if that ITV is significantly bigger than the CTV. And you can do three different things. You can dampen the motion, and we did that. We do that for the majority of our patients, the compression. I'll go over that in a second. You can use a duty cycle maneuver. That is, you can know the respiratory cycle and turn it on and off at different points in the respiratory cycle. Or you can chase or track the tumor. That's the hardest one to do, but that's probably the most elegant, because in the end, if that's done well, it would be the smallest ITV after you do your motion control. And I used to critique RTOG trials, and we didn't allow it to be more than 5 millimeters in the axial or 1 centimeter in the craniocaudal. And so that was pretty hard, because if CTV was this, and ITV was this, and then finally was this, we didn't want this one to be more than 1 centimeter in either direction of the target from the CTV, for the GTV, I'm sorry. And then 5 millimeters on the sides, because again, it's mostly craniocaudal. So that meant that your ITV could only be 5 millimeters up and down, because you always had to expand a PTV margin too, which is not easy. So you have to do something to try to really get that motion under control, or use some technique of motion control. Let me see what I'm saying here. And then these errors are institution dependent. People ask me, how big of a margin do I put on for PTV? And it's not a fair question, because my PTV may be different than your PTV. And so you have to, at some point, do scans at the end of treatment and see how much things moved around, at least during the treatment. And then also assume there's some interfraction setup error. But again, when we treat lung tumors, we want that to be as small as possible. So we used a 4D scanner then to calculate all this. And this is phase binning. You're basically doing a separate CAT scan at every one of these phases of the respiratory cycle. And then you're going to look at them after the reconstruction and notice how things are different in position relative to the table based on these 10 different CT scans. You could also do this. This is called amplitude binning, and I don't care which one you do, but this one's more common. They both work. And so you're basically performing separate CT scans. And then the 0 and the 50 in this particular convention, the 0 phase and the 50% phase represent inspiration and expirations. And then you can see where the tumor is at inspiration. You can see where the tumor is at expiration and get this motion envelope. And then you can also calculate from that 4D CT scan an average intensity projection, which is, for each voxel in the scan, they're averaging the Hounsfield number. And we use this one for treatment planning, because the treatments are long. If the treatments weren't long, then it doesn't necessarily make sense to use this for treatment planning. But this is the one we use. And we have to rethink that now that we're tracking more with things like MR-Linacs. Let me see. Yeah. And then you can get this MIP, minimum intensity, or no, it's maximum intensity projection, which will smear the tumor with a really dark, like the tumor is like the point of a magic marker, and you're just drawing back and forth, and it'll make a really dark impression then. And that's like what a MIP does to get the entire ITV. But as I said before, if the patient is breathing really irregular, you're going to get this ghost images and sawtooth images and stuff like that. So be paying attention to the motion when you acquire this 4D CT. And just a hint, abdominal compression really causes people to breathe more regular. In other words, if you have the luxury of breathing irregular, that is having periods of apnea, and then you do some sort of like respiratory motion management, the patient will start to breathe more regular. So if somebody, even if their tumor's not moving very much, but the normal tissues are, I'll put abdominal compression on them just to get their respiratory cycle to become more regular, and it's really reliable. And then the other problem with this MIP is that if it's touching something solid, if the target at some point in that respiratory cycle crosses the path of something solid, they'll melt together. So you got to be on the watch out for that too. And so you can't just use this MIP. You have to also use the other phases if it's abutting something solid like the diaphragm or the heart. I'm going to skip this because everybody has a 40 CT. Wait, sorry.
Oh,
So
actually,
again, let's sort of we
Dr.
summarize.
Timmerman,
Yeah.
I think that most centers, according to a survey we did, don't have 4D CT.
Oh, they don't.
So those slides actually might be very interesting. Yeah.
All right. So I didn't have a 4D CT either when I started. And then this is what some of the suggestions we had. We would do a fast spiral CT scan. Which oh wait, no, I'm going through, I'm sorry. Oh no, I'm sorry. These are the different options that you have. And this first one I wouldn't do because if you do a fast scan, you don't know which phase of the cycle you'll catch it in. And so that one I don't advise. You could really slow down the scanning acquisition time. And some of the scanners have a control of, how fast it requires a scan. And then it won't be a pretty picture because it'll be real smeared, but at least you'll get the extent of the tumor. You could do breath hold scans, either at inspiration or expiration. But these again, breath hold, if you say to somebody, hold your breath now, they always take in a bigger breath than they normally do because they're worried that you're going to make them have air hunger. And so instructions to patients like that are somewhat problematic because it makes the patient have to perform. And when you force the patient to perform, they don't always perform so well. But what we did was the last one. We would get a big scan of their chest, so that one we could use to see where the beams are coming in and things like that and make sure we didn't cut off any skin. And then we would zoom in on the tumor and do 3 to 4 slow acquisition scans through the tumor. And so they would then be fused in, and it was easy because they were in the same treatment position. And see, what we were doing there was we were sampling. We were scanning over and over again. And what you do, if you do like 3 to 4 of them, you're pretty likely to get the extent of the respiratory cycle in one of those scans, the inspiration and the expiration. And that was a bit of work, but it wasn't too bad because they were in the same treatment position. And then we would contour the tumor and use the motion from those mini CTs that were done inside the big CT. The big CT then was used for planning. Now, I don't get an average or anything like this from this technique, but again, I think this is a possible solution. There's a scribble on the screen now. Can't. So our technique is still the same 2023 as it was in like 2004 or 5, where we really pay attention to having the patient be comfortable. And, a big vacuum bag that's really engulfing them and getting their arms in good position so they're supported. We do a motion assessment, like a mini CT scan, mini 4D CT scan on the table. In your case, you could use fluoro or something like that, just to see how much it's moving and whether or not you're going to make that 5 millimeter limit, 5 millimeters up, back to baseline, 5 millimeters down, etc. We use abdominal compression a lot to achieve that. And I wish we wouldn't call it abdominal compression because it makes it sound kind of mean. What it's doing is it's trying to encourage chest wall breathing. You can breathe with your diaphragm or you can breathe with your chest wall. And the dampening motions are trying to encourage chest wall breathing because it's associated with less motion. And then we do a 4D CT using that compression. So the lungs increase their volume primarily by contracting the diaphragm. And the trouble with that is it creates a force vector that leads to motion primarily in craniocaudal dimension. And if it caused motion in all sorts of directions, it wouldn't be as bad, but it's primarily in the craniocaudal direction. But you can also increase your chest volume by contracting the intercostal muscles. And the intercostal muscles are the ones you use when you're really winded, like if you run a fast race. At the end, you kind of put your hands down on your knees and you stick your arms way out. And what you're trying to do is expand your chest wall because you're hypoxic and you're trying to get a bigger breath than just what your diaphragm can give you. So we all do this, and we all use these so-called accessory muscles of inspiration. So the intercostal muscles, the scalene muscles, etc. And it's not typical that we do this, but we can all do it at will if we want to. And so this is a front view of the lungs, and this is how they normally expand. So the diaphragm goes in and out. And that difference between here and here is the tidal volume. And the force exerted by that muscle, again, is primarily craniocaudal. But you can also breathe like this. This is another way to breathe. You can lift your chest wall up and breathe like that. And so now this over here is the tidal volume. And the beauty of that one is that on the left side, it primarily is a force to the left, and on the right side, it's primarily a force to the right. And basic physics, equal and opposite forces cancel. So a tumor inside the chest being influenced by these forces will tend to just stay still under these circumstances, but move up and down under these circumstances. Now, you can't ever completely eliminate diaphragm breathing, but you can dampen it considerably in exchange for this chest wall breathing. So let me see if this works. Oh, it doesn't work. So this is a patient with a tumor hiding behind the diaphragm. And if I had the movie, what it would show is it's moving really a lot up and down because it's right next to the diaphragm. And then we put abdominal compression. And what you notice is the diaphragm is higher now because we're compressing the abdomen. It's going to cause and that might be a downside because it's somewhat compressing the lung, but not too much. And so the diaphragm will go higher, and then the movie would have shown you that the tumor now, which was moving a lot, is now only moving a little, hiding behind the diaphragm. You could also do gating. Gating is picking a phase of the respiratory cycle and then trying to turn the machine on and off during that phase. And the tumor should be in a certain range of positions during that phase. And this is a common one is to use this one is, let's see, this is expiration, this is inspiration, expiration. So this one is end expiration. And so the machine will turn on as long as the respiratory cycle is below this line, and then turn off as soon as it goes above. And there's pros and cons to which phase you use, but you can use any phase. You could use inspiration, like turn it on when it gets up here and then turn it off when it gets there. The biggest problem with this method is the duty cycle. That is that the machine is off sometimes, and that means the treatment's going to be longer because you turn the machine off. Whereas abdominal compression that I just showed you doesn't have that problem. And the patient, this one's a breath hold technique where the patient breathes in a tidal volume, to some degree, maybe a bigger one than normal, and then the machine helps him hold that breath until he can't hold it anymore, and then they push the button. And then the machine turns off the radiation. And then tracking, we're doing tracking now on the CyberKnife, where the machine is moving with each breath following the tumor. And the MR Linux are getting close to being able to do that because to do that, you got to know where the tumor is throughout the entire respiratory cycle. And so what most of them do is have models that predict based on where it's been, where it's going to go next. And those models are accurate or not accurate based on the input to the model. And it's just far more complicated and not easy to do. And then this is, does somebody have a question? I guess not. And you know, you could use the multi-leafs technically, but Steve Jang proposed this. He's our chief physicist. I still haven't seen people do this, but it's about to happen, I think, with MR-Linacs. Now, in terms of treatment planning of lung tumors, remember what we're doing here is we're using a whole bunch of weak beams, each of which, when they penetrate the patient's body, they don't cause much entry damage because they give their highest dose at the entrance, but they're so weak that they're not giving much dose. But those beams all converge at the isocenter, and at the isocenter, then they really pack a wall up, even though they're each weak. And so that's the whole paradigm of a stereotactic treatment dosimetry. And what we'd like to do is, we're back to our lung tumor here, we'd like to give the PTV a high conformal dose. And that's pretty easy with the shaping of the beams and all that. So I think this is the easiest step, and the step that used to be people tried really hard to give, you know, full target coverage, but now it's just rather trivial. And this is where you win or lose. This is going to, and you want to fully cover that target. You don't always want to cheat on here or there for whatever reason. We'll talk more about that in a second. Why would you not cover the entire target? There are reasons, but not very good reasons. And so this is going to kill the tumor. Physicists have struggled to create homogeneous target dose. And for SBRT, that is a useless endeavor. We really don't care if there's heterogeneity of dose inside this target. And often you look at your planning system. Your planning system, when it comes from the manufacturer, has, you know, these constraints for treatment planning. And one of the ones that it really prioritizes is homogeneous target coverage. In the IMRT algorithms, that's one of the highest priority criteria. And I'm telling you right now, turn it off when you're doing SBRT, because you don't need that. Who cares if you overdose the tumor? Who cares if you have a hot spot in the tumor? Now, if there's something normal inside the PTV, that's a different story. And there always is, like in this case, it's lung, but that lung is history. That lung is never going to work again. Now, if it's a bronchus, you might have a different perspective, and we'll talk about that more. And then the second thing is we try to get a very steep intermediate dose. So this is the dose just outside the target. And this is hard. This is the hardest part of the whole SABR process, because I call it spill high dose. It's spilled dose that's significant. This dose can injure whatever it touches. Not as high a probability as the prescription dose, but it's still a pretty high dose, because remember the prescription dose, was 6,000 in this case. And this dose is 3,000, but 3,000 in 3 is still a very potent dose. And so whether you're good at this or bad at this will all depend on this dose, the dose outside the target, and how you construct it. And in this case, I seem to have polarized it front to back. I don't know why, but I think I was trying to avoid this airway right here. And then finally, and you have to accept this, you can't have a compact high dose if you don't, whoops, where I'm going here, if you don't have a massive low dose. And so people that, I don't know how many of you worry about V5 when you treat lung cancer. V5 is the low dose that, and I don't care if you're treating 30 fractions or 3 fractions, V5 doesn't matter. The V5 is a dose below the threshold of a sigmoid dose response curve. And the papers that show that it had implications toward treatment toxicity were flawed. And so you can't have a stereotactic treatment if you don't exchange this very large low dose bath for a high dose, very small high dose conformal treatment. You just have to do it. So don't worry about this low dose bath. And then you would like to make sure you don't overdose structures, or if you do overdose them, that you know about it. So that if you know about it, then you're thinking about if it's injured by that dose that's beyond what would get it in trouble, how's it going to fix itself? And so those are I gave them an order of priority almost though, because in terms of planning priorities, we always respect the spinal cord constraint. And we usually respect the brachial plexus constraints because their consequences are so catastrophic. And so that's our top priority. So if there's a tumor next to the spinal cord, we will respect the spinal cord constraint before we cover the tumor fully. And then the next one is we cover the tumor, and we respect compactness constraints. And that has to do with the fall off. D2CM is the dose, the highest dose 2 centimeters away from the tumor, and R50 is like a conformality ratio of the half dose line to the target volume. And these are made up constraints, but there's some way of measuring the steepness of the gradients. And you can do that by having many beams, many angles, many arcs, and that achieves a dose fall off. Let's see, something went wrong here. And we put in the protocols years ago, and many of you have these, and if you don't, you can email me for them. These compactness constraints, that is how to construct dose and then compare it to your friends to see if you were able to get the dose to fall off rapidly in all directions. And here's one thing about, you don't probably do a lot of 3D as much as you used to, but I did almost all these treatments with 3D therapy, 3D conformal therapy. Normally, when you treat with 3D, if this is the target, you would actually put a block margin on. You'd treat bigger than it actually was, so as to avoid disequilibrium at the edges of the targets and the edges of the field. And you could do a negative margin, but this, you wouldn't get full dose from this beam on this edge of the target here if you did this. But if you use a lot of beams, that's okay. And so let's say you have a point outside the target, and I don't, for some reason my point didn't show up, but pretend there's a point out here. If you have a point like right here, by not treating that point's going to get less dose, right? The beam profile looks like that, so you get not full dose at the edge of the block aperture, but you get full dose inside it. And if you do a lot of beams all together, you will get full dose coverage. But consider this strategy where you don't give the full block margin. You agree to let this be underdosed a bit, and it will be. But if you do this a lot of times, you'll get most of the target covered with seeing the full beam, but just this edge won't. But the beauty of this is that you'll get a steeper gradient outside the target because there's no primary beam outside the target. And I've used this technique for years when we did 3D conformal, and it really helped create better gradients. And then you just prescribe to a little bit lower isodose line. So we would typically prescribe to like the 70% or 80% isodose line with our treatments. And then the third priority is respect normal tissue constraints. And I know that really catches you off guard that I didn't put that number one, but we cover the target and do not sacrifice the dose, those other two priorities for normal tissue constraints, because the recurrence of a tumor because you missed it by trying to respect the normal tissue tolerance, you might underdose part of the tumor. You will then get a risk of tumor recurrence in that exact location, which is exactly what you're fearing. And now maybe you won't say it was a radiation toxicity, but it was toxic to the patient nonetheless because their tumor recurred in a terrible place. And what I'm asking people to consider is that you can improve the intermediate dose to the point where the injury that you cause might only be a temporary injury. That is, it might be a wound, but a wound that will heal. And I'll talk more about that later. And then go ahead to the treatment. This is the treatment verification and delivery. This, I don't think I put anything down here, but that's the fourth step in the process. Now, any questions so far?
We have a couple of questions. If you want, if you want them to answer now, or you prefer to wait until the end. But since we're here at this point, and you were talking about the you showed that table with the RTOG protocol with those control. They were asking what RTOG is that.
Oh, these were the old ones. The radiation therapy.
Okay, so there is an answer actually. I don't know. Maybe could it be RTOG 0813?
Maybe that would be the newest one of
the
those.
Newest. Okay,
so that would be the newest one.
Perfect.
And they haven't changed. They really haven't changed.
Okay.
Yeah.
Perfect. And actually, I mean, as an impression, I mean, great pictures, great cartoons that you showed to show the creation of the ITVs and PTV. It was amazing, and also about there were comments about the explanation about the abdominal breathing and thoracic breathing. Is there any? Would you actually advise to stimulate abdominal breathing respiration better than thoracic, or would you work with the patient on what is best for them?
We used to just squeeze really hard with the plate on the abdomen, but that was kind of mean. And so what we do now is we squeeze quite lightly on the abdomen, and then we coach the patient we tell them, as you take in a breath, if I put a plate on your abdomen, if you're laying on your back, what'll happen is every breath you take, you're going to push against that plate, because it's the motion from diaphragmatic breathing is to protrude the abdomen, because the abdominal contents get pushed down and they stick out the front. And so what we tell them is, as you take in a breath, try not to push any exertion at all on that plate. In other words, don't. And if the only way to do that is to chest wall breathe. So if you sit in your chair right now, I can sit here and lift my chest up and breathe in and out, and my gut literally sucks in with each breath. Normally your gut protrudes with each breath, but you can, if you chest wall breathe, you can suck your gut in with each breath. And then that plate just reminds the patient to do that. You don't have to torture them. We used to, but we didn't know what we were doing. And once we figured out we were actually causing chest wall breathing, we redid completely our approach to the simulation. And the plate doesn't press very much at all on the patient, but you have to coach them, and that's what it does.
Perfect. And let's do one more question. And this is from the beginning of when you were talking about the immobilization devices, and you talk about the backlogs that you create within your immobilization. Any challenge to use that backlog with MR-Linac because of reception?
The certain brands have a little piece of metal in them for the valve. And so you got to get the kind that doesn't have metal in the valve. Okay. And they're not as fun to use, but you can do it.
Perfect.
Otherwise, the metal in the valve will kind of go toward the magnet.
Okay, great.
We bring the frames right into the MR-Linac, and we do abdominal compression.
Right. Perfect.
Yeah.
Okay, so yes, you can continue. Those.
Okay, do I have an hour and a half? Did I understand that right?
Yes,
Yes,
yes, you do. And
And I
actually,
won't go that whole amount, but I wanted to just make sure I didn't go
yes.
over. Okay, next I want to talk a bit about central tumors in the chest. And this was a paper I wrote a long time ago, but it described the early Indiana experience where we treated T1 and T2 tumors, and those tumors could be anywhere in the chest. And we had, pretty good local control and not great survival, but there's a lot of competing causes of death for these patients with medically inoperable stage 1 lung cancer. But we didn't really make any restriction about where the tumor was in the chest. And then we noticed that people with central tumors, and this is arbitrary, but I defined central with this picture. Anything within 2 centimeters of these named airways. What you've got here is a tree, right? You got a bronchial tree, you got the trunk, you got the big limbs, you've got the branches. And I want you to notice, even on this little cartoon, the big trunk has these kind of rings here, and that's the cartilage. Cartilage is going across these. The named major bronchi have that same cartilaginous rings, but as we get out here more, they don't have them anymore. And then there's a blood vessel that follows every one of these. There's a blood vessel, a vein, and an artery that follows every one of these. And so those are bigger as well, closer to the trunk than they are out toward the periphery. And what we noticed was there was way more toxicity if your target was inside this or even encroaching on it, touching it. But let me tell you that they did not have massive hemoptysis, but they nonetheless had higher toxicity, including some toxic deaths. And so, what was causing this? And you might think we just stenosed the bronchus, and it was not that. So we don't think that we caused named bronchial stenosis. And I think it had to do again with the cartilaginous rings holding them open. We definitely could have damaged the mucosa, and I'll show you a picture in a second, but I don't think that was the primary problem. What we saw more was sublobar atelectasis, and these are more peripheral. And then I think the way to try to understand this is to remember what SABR is. SBRT or SABR is ablative. It disrupts function. And then you say to yourself, what is the function of the tissue that I'm ablating? And in the case of the airway, what's the function of the airway? It's a conduit. It's a pipe that lets air from your mouth get into your lungs. And it's the transit, it's the highway that allows that. But it has another function that we don't always think about. It carries out the function of pulmonary toilet. That sounds terrible, but the air you breathe is dirty. The air you breathe has bacteria in it. And so the airway is involved in, if you breathe that in, getting it back out. And so it's a function of pulmonary toilet that these two functions both could be disrupted. We could stop it from being a conduit, and we could stop it from carrying out pulmonary toilet. And it's very likely that the central tumor problem is related to pulmonary toilet. Now, you're probably going to be surprised and you say, no, it's related to massive hemoptysis. That was not the problem with these patients. The problem with these patients is they just simply couldn't breathe and their pulmonary function declined. They were not bleeding out their mouth. These were patients that ended up, if they died, for example, they died of complications of COPD. And this is what it looks like. So here's a tumor that's very close to a major airway. By the time I expanded it, looking here how it's expanded, it resulted in an airway collapse of a subsegment, and a bronch will show it look like this. It just looks terrible. So you've denuded the lining of the airway. So now there is no lining of the airway. And so the function of getting the mucus and getting the dirt out of your lung couldn't be accomplished, and it ends up looking like this, and by and by the whole segment collapses. So we damage the function of pulmonary toilet. When we did RTOG 0236, which was later, we were at that high dose, that's 60 gray and 3 treatment, but we excluded these central tumors because of that. So if you had a tumor this close to the airway, you couldn't go on RTOG 0236. And they had fewer toxicities then because of that early Indiana group experience. We had the bad toxicities, but 0236 didn't have the bad toxicity, and they had much better survival too. This is so in these cases, when you have organs, all organs are connected to the body by a hilum, and the hilum is either bringing blood supply or it's allowing something to get out of the organ. So your spit glands have a hilum, your liver has a hilum. And I think when you use ablative treatment, your danger is that you could disrupt the function of that hilum. In the case of the lung, its function is pulmonary toilet. In the case of the liver, the function is to get the bile out of the patient. And so you always want to be a bit more careful. I'm going to go a little faster. So people have tended to use more fractions when they're treating in those hilar areas. This one is, let's see, this was a bad case report in the New England Journal where they treated a central tumor and then described this terrible calamity, including hemoptysis, but that's pretty rare. Let me see, I'll go through this. Sorry. So I think that the data indicates clearly that central tumors are more risk than peripheral tumors. And so what I would recommend in the future is, number one, probably use more fractions. And by the way, you don't get the choice to just necessarily switch to fractionated radiation, because I guess you have the choice, but fractionated radiation doesn't even get to first base very well. It's only, if you give 20 or 30 fraction regimens for lung cancer, your long-term local control is only in the 60% range. And getting the local control is just first base. You want to go ahead. Oh, and so I think it's still better to give SBRT even if it's a central tumor. So a couple points. One is that I think that you have to modify the treatment a bit from a central to peripheral to try to add safety. Number two is that, oh shoot, I forgot number two now. Let's see, sorry. See, I'm getting old. Number two is that the hemoptysis probably won't be their complication. And so the irony is that there's now definitions for ultracentral tumors that include if the tumor touches the great vessel. And I have treated hundreds of patients with tumors that touch great vessels, and I've never had a complication. So the esophagus is a problem in a central tumor. If you hit the esophagus, they'll get a bad esophagitis. But the great vessels, I don't even worry about them because I just never had a complication from them. I have had patients who have had massive hemoptysis over the years, but it was never the great vessel that bled. It was always a small vessel, and it was pretty much always tumor recurrence. In other words, I don't know if it was the SBRT by itself that caused the massive hemoptysis. It might have been in conjunction with a tumor recurrence. In other words, the SBRT was unsuccessful. But I don't think by itself we see massive hemoptysis. But this pulmonary toilet problem is an issue. And what I'm arguing now to do in central tumors is this concept of pulsar. Now, pulsar is taking a SABR regimen. So let's say your SABR for lung cancer is 18 gray times 3. And instead of giving the treatments every other day, every third day, which is what I did for all those years, some people give it every day. You do the first dose of SABR and then you stop. That first dose is 18 gray, but let's say it was even 10 gray. 10 gray will stop a tumor from growing for months. You know that because you can give 8 gray and 1 to a bone met and compare that to 30 gray and 10. And at 3 months, they're absolutely the same in terms of local control. So 8 gray is enough to hold a tumor in check for at least 3 months. Now at 12 months, maybe 8 gray is weaker than 30 gray and 10, but at 3 months, there's no tumor progression. So you have now the luxury of waiting for a month at least between the SABR treatments. So you stop. What I tell you to do in that time is monitor the biological processes. You might get a really nice response. Maybe give drug therapy, and then you do the next treatment. Maybe weeks or a month later. And there's 3 benefits to this, but the first one is key for what we're talking about. Split course treatments are less toxic, and all of the fractionated radiation split course randomized trials showed that they were less toxic. Now they had tumor progression problems. The tumor liked the break too when you were giving 2 gray per fraction. But again, with bigger doses like SBRT doses, you don't have that problem. And so why are split course treatments less toxic? Why would it be less toxic if you waited a week or 2 between your treatments for a central lung tumor? Here's a randomized trial from Canada where they compared a week apart 8 gray times 5 with a week apart between the 8 gray doses for prostate cancer versus every other day. And sure enough, this was less toxic. The acute toxicity was statistically less. Importantly, there was no PSA difference in terms of PSA control between these arms, so that the extra week allowed the patients to have less toxicity, but didn't cost them anything. And that wouldn't be true if these doses were 2 gray, but at 8 gray, that is true. So why is pulsar less toxic? The breaks allow tissues and organ healing and repair. And I'm not talking about cellular repair. I know you all took radiobiology, and in radiobiology, all they talk about is whether a cell repairs or not. And the half-time for cellular repair, as you know, is 1 to 2 hours. So if a cell was irradiated in 1 to 2 hours, half of the repair will be repaired if it's going to repair at all. And so if you multiply that by 5 half-lives, that's by the next day, so that's 5 to 10 hours. So by the next day, 99% of all the cells that are going to repair will have repaired. And that's the whole basis for fractionated radiation in terms of that. That's not the same as tissues, though. Tissues and organs have many cells, and they're organized in ways that are unique and elegant. And tissues can repair even though many cells have been killed by the radiation. And the whole field of surgery is based on this. So the fact is, every time somebody's, I guess they're just got their mic on. So the surgeon injures the patient every time they operate on them, but the tissues repair. Cells don't repair that got cut, but the tissues repair. But they're much slower. The half-time for tissue repair is weeks to months. So if you have a big surgery, you're not going to be spry for at least weeks to months. So it's way slower than cellular repair. So this is why pulsar takes advantage of this by letting those tissues and organs repair if you give several weeks or months between treatments. And they recover their tolerance. This is a paper from Paul Medine, who did the spinal cord tolerance in pigs to a single fraction. He found that a single fraction of 20 gray was the ED50, the dose that caused 50% myelopathy was 20 gray, and it was to the spinal cord. It was a glancing dose. And then, but many people don't realize he did a second experiment where he gave 30 and 10, which is again considered a spinal cord tolerant dose. And then a year later, so if he would have given a single fraction now, then the probability would have been really high of causing myelopathy. But he waited a year and then tried to repeat these ED50 experiments. And interestingly, it was the same. In other words, the spinal cord tolerance was completely recovered after the 30 gray and 10 if you waited a year. That's very encouraging for retreating people who've had previous radiation. Now, I don't know if it happened in 6 months or 9 months, but by a year, it completely recovered. And this argues against the old view of tolerance, which was like you were filling a bucket with water, and that bucket's tolerance was the top of the bucket. And once the water hit the top of the bucket, now dose beyond that would cause toxicity. So you filled the bucket, and once it overflows, you're going to cause toxicity. And so what Madine's data shows, and Pulsar is also showing, is that the buckets might fill, but they leak. And they leak with time. And so the more time you allow, the more of the previous radiation that will be forgiven and allow you to give more aggressive doses against tumors. And this is all tissue recovery. So you got a leaky bucket that doesn't fill. Well, that's all I got. And I'm happy to take questions.
Yes, thank you so much. Excellent presentation. And we have a couple of more questions. With regard to CyberKnife, when you mentioned the use of CyberKnife, when do you choose to use fiducial tracking, or do you prefer abdominal compression with 4D CT for CyberKnife?
Interesting. My answer is going to surprise you. We would use both. That is, I would rather track a tumor that's just moving a little than track a tumor that's moving a lot. So we would commonly use abdominal compression in conjunction with tracking, and now the tracking was more reliable because it wasn't such a dramatic movement that I was tracking.
Perfect. Yeah, good. Yeah. So both is good. It's always good. I'm talking actually, there was talking about both things. There was a question interesting, I think. How often will you use mixed techniques for controlled respiratory movement, to control the movement of respiration?
Yeah.
I don't know. I'm thinking maybe if you use an abdominal compression plus 4D CT, or I don't know, it's something.
Oh yeah, no, 4D CT.
Mixed techniques, kind of.
Yeah, like when we do abdominal compression, we try to watch the tumor behave itself and stop moving as much. And then under abdominal compression, we do the 4D CT. So the point is, the 4D CT should be done using the method of motion control that you plan to use. And so we would, now in the old days, I didn't have a 4D CT. So I would have to sort of make the motion of the tumor on the planning scan that I had, which was not a 4D scan, relative to other landmarks. And I know that's not ideal, but that's what I did. And so you just have to try to really understand where the tumor is moving throughout the cycle, and then see that trajectory on whatever you're planning on. And the fancy new machines just make that easy. It can be done without them. It's just that, I think that, like, for me to do an adaptive treatment, I can do an adaptive treatment without an adaptive machine. It's just a lot of work. You have to re-simulate the patient and all this. So and that's not a bad thing, but most of the technologies make our lives easier, not always better, but easier. And, so you can do things without spending money on the fanciest machine.
Perfect. Thanks. A question about central lesions. Is there a limitation on the size of the tumor to safely do SBRT for central lesions? Or
the bigger the tumor, the less safe. The bigger the tumor, the less safe the tumor is. And so the question is, like if you have a 5-centimeter central tumor, for surgery, that pretty much always means pneumonectomy, which is not a safe procedure. And for us, it means, you know, because we treated on the Indiana studies tumors up to 7 centimeters. So beyond 7 centimeters, I can't tell you much, but this week, we treated a 25-centimeter sarcoma in the hilum of the left low lung that was about to be completely obstructing his left lung. And so we did it. Now, was that smart to do? Is that safe? No, I don't know. I mean, but you know, the patient understood the risks. We went over that carefully with them. And we tried really hard to spare the epithelium of the airway that was going right through air, had air in it. And I hope it works, and that he doesn't lose the left lung entirely, but that's what he was facing. So, you know, this is always like the radiation oncologist is a person who doesn't want to cause toxicity, you know, and, you know, so wants to be considered safe, but that's judged by your peers. But, you know, the patient sometimes needs a treatment that's very risky. And, you know, that I get a lot of those patients, and I just try my best to use what I was trained to do, and advising the patient what the risks are. So yeah, I would treat a big central tumor. I would probably give it at least 5 treatments, you know, and then I would do pulsar, because now I have pulsar. That's a pearl for you, man, because you know, pulsar is profoundly less toxic than the same saber given every other day. And it really has gotten me out of trouble lately.
Great advice. Yeah, agreed. There is a question about, do you involve thoracic surgeons in evaluating SBRT plans, or is there a conversation you have with them? Or?
I wish we would have, because in like the brain, you know, I treat brain tumors, and we have a wonderful relationship with neurosurgery, and they do go over the volumes before we treat them. And I don't know why, but we didn't do that for thoracic surgery when we started lung treatment. And maybe we should have. I think there wouldn't be as much animosity. Now at this stage, they don't want to do it. So you know, they're not going to get reimbursed for it. And so they're not. But I think that maybe we made a mistake years ago where we didn't engage our surgeons as much and make it part of their arsenal too, just like we did with brain radiosurgery. But no, we don't involve them.
Okay. In case for multiple lesions in the lung, would you recommend to still do SBRT? And what would be the recommendations?
It's a lot of work. And second, I would recommend an isocenter per lesion, unless they're really close together.
Right.
And number 3, I would probably use coplanar beams. And I usually really argue for non-coplanar beams, but when you treat multiple lesions, the accounting just gets crazy. And I think it might be reasonable then to use just coplanar beams. But
just
and
to
then
avoid
avoid
exiting or entering through the other lesions, just for that.
Yeah. And then the final thing I'm going to say is something that might surprise you, but we do this routinely in the brain, and we're starting to do this in the lung for Mets when they have multiple Mets, is we treat lesions on different days. So if 2 lesions are in the same plane, let's say you have a axial plane and there's two lesions in the same plane. If you treat them on the same day, then the dose overlap between the 2 is probably going to be in the intermediate dose range, and it's probably going to destroy the lung between the lesions. So we treat one on Monday. Now that lung that's between the 2 lesions only sees the single fraction dose that's in the low dose range. And then on Tuesday, we do the other lesion, and same thing there. And so that overlapping lung dose is going to see a much lower daily dose therefore it will tolerate it much better. And the tumors don't care because they get, pretty much the bang dose anyway. So we call that distributed treatment. If the lesions will cause toxicity by treating them on the same day because they're so strategically close together in the same axial plane, we convert it into a fractionated treatment for the dose fall off. So the dose fall off might be much lower on that day. And so we treat lesion A on Monday, lesion B on Tuesday, lesion A on Wednesday, lesion B on Thursday, etc.
Perfect. Great, thank you. Questions are coming now, so I'm trying to translate them while I'm expressing to you. So there was a question about when you use compression belt and for VCT, most times, the infrared camera won't detect the movement because it will be little. How do you resolve this problem, or if you have seen that as a problem?
Yeah. Number one, we don't use a belt. A belt would constrict the ribs and keep the ribs from lifting. And so the compression actually just comes from the front, and the frame will facilitate this because you can hook the compression device to the frame, not the patient. And the belts will, your ribs go way down low, almost, you can feel your hips and your ribs, and they're close together. So if you put a belt on, you could catch those ribs and prevent them from lifting with each breath. Number two is, I'm trying to think what you said. What was that question again?
It's about using the compression, abdominal compression, and for DCT, and the fact that the infrared camera, because the movement is so
if a person, if a person is just being simulated, the best place to put the infrared thing is on the abdomen. In other words, you're trying to track the respiratory motion. And because the chest doesn't move with normal respirations. And I mean that catches people off guard. They always want to look for respiratory cycle motion in the chest. The chest doesn't move with normal respirations. Now, if I do abdominal compression, I will cause the chest to first start to move. And so once a patient is breathing under abdominal compression, now, instead of monitoring the abdomen, you should monitor the chest for motion, only under abdominal compression. But if you don't have abdominal compression, if you're just letting them breathe with their diaphragm, you should be monitoring the abdomen for respiratory motion, not the chest. So yes, I do cover up the location, but I move it to somewhere else to, so that once I've achieved my victory, which is that they're chest wall breathing, the chest will move like crazy, and now you'll be able to track it from the chest.
Yeah, excellent. Yeah, good advice. There was a question from before, if for central lesion, if you do the changes on Hansfield units between air and tissue or water on the PTV. Is there anything?
Yeah, so it's interesting because in the original RTOG, we didn't correct for heterogeneities. And we gave a dose of 60 gray and 3. And then people have asked me, why do you give now 54 gray and 18? Excuse me, 54 gray and 3, which is 18 gray per fraction. Remember, there's two factors that would affect the PTV dose. One is that as the radiation comes through the lung, it streams because the density is so low. You end up with a much higher fluence at the tumor target once it gets there because of the streaming through the low density lung. That would sound like it would increase the dose, right? Because more fluence hit the target than what you expected. But then there's a secondary effect, and there's a disequilibrium at the surface. It's almost as if you come across now a new structure after you've been traveling through air. And so you'll have a disequilibrium at the entrance of the beam, and it turns out that will lower the edge dose. And it turns out that that's more important than the fluence that I just mentioned at the edge of the PTV. So the prescription actually went down. We gave less dose than we thought. Now, the center dose of the tumor was more than we thought, but the edge dose was less than we thought. So 20 gray and 3 is the same as 18 gray times 3 if you use heterogeneity correction in a valid heterogeneity correction algorithm. And those are equivalent doses. If you give 20 gray times 3 without heterogeneity correction, it's equivalent to 18 gray times 3 with heterogeneity correction.
Yeah, perfect. And I guess, yeah, we maybe have a time for one more question. Let me ask this. What would be the best time to start steroids treatment for central lesions? From the beginning or when the symptoms appear?
Oh, I gave them, if they don't get immunotherapy, because steroids screw up immunotherapy. But if they're not getting immunotherapy, I always gave 4 milligrams dexamethasone. I don't know if they have that in all countries, but 4 milligrams dexamethasone with each treatment. So they would come in, I'd give them a pill, they'd get their treatment. The next time they came in, I'd give them another pill. So it wasn't a regular schedule. It was just with each treatment that I did it.
Right. Perfect. I think we're good. This was amazing, excellent presentation. I just want to relay all the messages that are coming in the chat. Great presentation, outstanding. Benjamin, I don't know if you have any question or anything else to say.
Yeah, this was amazing, Dr. Timmerman. I learned so much too, and this is after, even training somewhere where we did a ton of lung SBRT. I took some notes. I'll kind of share the pearls for everyone who wasn't able to join today, but we had hundreds of physicists and radiation oncologists who now appreciate motion management. I think you really drove home that point. And for those of us that don't have 4DCT, I think you showed a really great way for how to go about doing it, and just all the tips about the abdominal compression. Really, I think this will help us improve our practice. And, some of these things, even we can think about when we're treating other areas where breathing is a consideration, like upper GI. I think the same thing, trying to reduce so just really, really helpful, like fundamental understanding. And I'd like to invite everyone, if you want to show your camera, we can take a quick picture with Dr. Timmerman before he heads off and enjoys his weekend.
Well, thanks for inviting me.
So if this is the RCC sign, Dr. Timmerman. It's sign language for R.
Oh.
Yeah. Rayos. And 1, 2, 3. Unos más. Whiskey. Uno más. 1, 2, 3. Ok. Muchas gracias a todos. Gracias a Acro por la traducción activa, y espero que ustedes disfruten el conocimiento mejor para el beneficio de nuestros pacientes. Nos vemos la próxima vez.
Okay, bye-bye.
Bye.
Bye.
Gracias, bye.
Gracias.
Gracias.